All right, looks like we're live. Hi, everyone. Dr. Tom Nabity.
Dr. Santa Ana here.
We're topic tonight is arthritis and arthritis repair. What sort of treatments that we can offer you here at Michigan Center of Regenerative Medicine to help you with any of your arthritis pains. And I guess before we jump into treatment, we thought we'd talk just a little bit about arthritis because it's such a common term that's just thrown around and it can mean different things to different people. So Dr. Santana, you want to take that one? Just kind of break down how you manage, or rather how you separate the different types of arthritis.
Yeah. So when you talk about arthritis, it primarily pertains to a joint. So any interface between two bones is a potential area we can have arthritis. So when we talk about arthritis, it's not really a thing or a substance. It's a description of how your joint space is between those two bones. So there's different kinds of arthritis that we see normally. One is your osteoarthritis, which is your normal wear and tear degeneration of the joint from activities and trauma and things like that. The second other type of major classification of arthritis is your autoimmune or inflammatory arthritis. So that's where you would have your rheumatoid arthritis, lupus, psoriatic arthritis, where the main inciting factor for the joint degeneration is your immune system attacking the areas. Now, Dr. Nabity, how do you differentiate the two? What do you look for, and how do you kind of pick one versus the other? Because that kind of determines the treatment plan, right?
Yeah, the treatment definitely for the two are different. If you're looking at an inflammatory arthritis, the symptoms are usually going to be more immediate onset during flares, episodes of severe pain, followed by more your general chronic pain. And then there's going to be symptoms usually outside of those joints. For example, for rheumatoid arthritis, we're going to have problems usually with the hands. For psoriatic arthritis, there's going to be a lot of problems with skin, in addition to other joints being involved. Whereas in our osteo or wear and tear arthritis, multiple joints certainly can be involved, but it's more of a slow and steady progress type of history. Oftentimes a trauma might be involved at an earlier onset, like an old football injury or an old car accident, and then years later, the pain starts to get to a point where your patient really seeks treatment. As far as the different types of therapies we have to manage them, the rheumatoid or the inflammatory autoimmune arthritises are going to need to have some sort of a management to decrease the immune system from attacking itself, because that's essentially what's creating the problem in the first place. You can still do some of the pain management stuff that you do with the wear and tear arthritis, like cortisone injections and bracing and physical therapy. Those sorts of treatments still have a role in the inflammatory arthritis, but for the wear and tear or osteoarthritis, which is the most common type of arthritis that we see, those are really the mainstays of treatment, other than the types of regenerative treatments or seeing an orthopedic surgeon for joint replacement.
Yeah. I mean, those two arthritis are they can coincide or coexist together. You don't necessarily have one or the other. So you can have two things going on at the same time, and that can make things really complicated. Yeah. Like Dr. Nabity said, the osteoarthritis, your typical degenerative arthritis, typically gets flared up with increased activity. So a lot of people would have more pain, let's say, at the end of the day versus the beginning of the day, versus the other type of arthritis that inflammatory autoimmune type arthritis can pretty much flare up as soon as you wake up. So it may not be activity related, but you're right. It gets really complicated, and there's different ways that we treat them, because one is we treat them with autoimmune arthritis. Treatment is primarily just maintaining and preventing your immune system from being overly active. And so there's medications for that to manage it. But I think for the purpose of this talk, we'll kind of focus more on the osteoarthritis realm, where we can do a lot of good in terms of regenerative medicine in treating this degenerative type arthritis that people are plagued with.
So how do people know if they have osteoarthritis? What would you say the typical diagnosis is made using what sorts of criteria?
So I kind of like, the way I look at it, I ask for kind of like a brief history, exactly kind of like, when do they usually have the pain? Is it usually after an activity, something specific? Is it in the beginning of the day versus the end of the day? So typically that's regular osteoarthritis, typically more at the end of the day, usually related to an activity that they do, or it gets better with rest, or kind of offloading the joint and stuff like that. A lot of times you get better with also anti-inflammatories like Motrin or naproxen or even Tylenol can help with that pain too. And then further back from that, just kind of thinking about, have they had any type of injuries to the area? Have they like a prior sports injury there, or a trauma or a fall that kind of snowballed this whole event? So just kind of trying to piece bits of information and the history together helps us kind of figure out what the arthritis is.
So a lot of times people come in and they're told they're bone on bone with their X-rays, right? I mean, it's such a common thing to say, and
sounds scary.
Sounds scary. Communicate how severe the problem is, and like you and I were talking earlier, it's a lot easier to describe arthritis as being a strictly anatomical problem and not a biological situation, and it's more complicated than just, oh, your bones are touching each other. You have arthritis. There's a lot more going on in the joint. And if we have time and really get into it, a lot of what we're doing in regenerative medicine is truly that. It's changing that environment that's in the joint and not just the structural look of it. But when people tell me they're bone on bone in x-rays, it's an important thing to distinguish between true bone on bone and having no cartilage left versus with the x-ray images, those shadows are overlying and it looks like one bone is on top of the other. But from a diagnostic standpoint, that's really the first thing. Most patients come in, they've had x-rays done, they've been told they're bone on bone, they have arthritis, and what can we do for them other than joint replacement?
Yeah, we hear this a lot, like this bone on bone term. Honestly, if it truly is bone on bone in the true sense of the word, if it is bone on bone, it means that you won't even be able to move that joint, because it's kind of like having no interface at all between those two bones. So anytime you try to move those, it's going to be locked. It's kind of like having gears with no oil. It's going to be locked. It's going to be very painful just to put any weight on it. I think just having the simple fact of somebody being able to walk to the clinic and actually do range of motion, just be able to move their joint with some degree, it means that they do have some cartilage there left, So I kind of explain the patient in that way, that it's not truly bone on bone until it truly is bone on bone.
So I'm guessing we have some patients watching tonight or at a later time even that have been told they have those findings and that their next step is joint replacement. If I were your patient coming in and I had a knee issue or a hip issue and was looking at joint replacement surgery, I've tried all the other pain management stuff. I don't just want to block the pain. I want to try to fix the problem. What sort of treatments at our clinic would you be discussing with the patient other than prepping them for surgery?
Yeah. So the two major things that we specialize here in the office is PRP, or platelet-rich plasma, and bone marrow stem cells. We also do prolotherapy, but I think in the realm of arthritis and the severity of the arthritis that we see, that's pretty much one of the, I don't use it that often as far as what I recommend for patients. I usually recommend PRP and bone marrow stem cells. So the idea with PRP and stem cells, they're all within the umbrella of regenerative medicine. And the idea with what they do is they try and regenerate the joint and try and establish that homeostasis from arthritis. And by doing so, it actually stops the progression of arthritis in its tracks. The more and more we learn about regenerative medicine, the more and more we're really understanding what arthritis is and how regenerative medicine addressed the arthritis. Before, also being a physician, when we learned about arthritis, we just learned that arthritis is that, once you lose the cartilage between the joints, then that's arthritis, right? It's just it's how much cartilage you have left. Now we're learning more and more about how the joint works and how arthritis is. So it's not just as simple as having cartilage in your joint or having little cartilage in your joint. The whole concept of arthritis goes beyond just that thickness. It's also that the homeostasis and the chemical soup that you have in your knee that determines whether it's a severe arthritis that you can't walk on, or an arthritis that you have it but still be able to kind of function well.
Yeah, the easiest thing to say is just to look at an X-ray and, well, your cartilage is gone. You need a joint replacement. Well, that leaves you thinking, well, the cartilage must be the problem. I just need to regrow my cartilage. And it's more complicated than that. There's a lot more pieces involved in the healthy environment, microenvironment of that joint space. And that's, I think, where both of us would say regenerative medicine comes in. Because we see great outcomes with what we're doing. We're in the 70 to 80% outcome range of people getting pain improvement and functional improvement. But not every time do I see cartilage grow.
Same.
And I think that's, our colleagues around the country, we're scratching our heads. Well, why is this patient so much better? I think the first thing people would say, well, it's all placebo. It's a placebo effect. Well, that's not necessarily going to work with the animal studies that we're seeing the same sorts of things where you see animals, dogs running and moving like younger dogs again. But their X-rays didn't change. Well, why is that dog doing better? There's really no placebo effect in an injection given into a dog. So why this stuff's working, I think, what we're doing, working with our different societies and really trying to figure out by tracking outcomes, connecting dots, saying, these cell concentrations injected in this type of a patient grew cartilage. This one didn't grow cartilage, but they both had good outcomes, and getting more and more data so we can be more and more informative during our consults with our patients.
Yeah. At the end of the day, it's like, the goal of what we do is not to grow cartilage. The goal of what we do is so that you can go back to doing things that you want to do, whether it's playing golf, playing with your grandkids, being able to tolerate going to the grocery store, standing around, going to a concert, being able to play the sport you want to play. That's the goal. The growing the cartilage is just the cherry on top of it.
Yeah.
This whole arthritis thing, it's more complicated than just that, and that's why we like to focus more on the functional outcomes that our patients get, and then hopefully at some point, like Dr. Nabity said, as we get more information and more data coming in, we'll really start to understand why things happen one way or another. Regardless, the outcomes are still better than a knee replacement or any type of replacement surgery.
And we haven't burned any bridge for those patients that still need to go on towards a joint replacement. We haven't done anything that's going to prevent them from having a good outcome, and if nothing else, we've improved that environment such that the joint's more likely to take that the artificial joint is going to seal to the bone, and I would. Without having data, but I would think that there is going to be a decrease in failure rates in those that have done some sort of regenerative procedure prior to their joint replacement surgery.
Yeah, that's true. And I get, like you just mentioning the joint replacement patients, like how many joint replacement patients have we seen who still has issues with pain, right? Mm-hmm. I mean, that's a completely reconstructed joint. For all intents and purposes, that's a perfect joint. But that kind of tells you that it's not just that joint space that talks about arthritis. There's a lot more that goes along with that. And if we're just focusing on that mechanical, joint space, then we're missing the bigger picture. Right.
Yep. No, I think it's a great point. I really like it. I'm going to steal that one.
No, I just thought of it now while you're talking about it. I think, like, at the end of it, too, I try to explain this to patients. I tell them that, I don't know how much cartilage is going to grow in your joint. But what I do know is it's going to stop this process of degeneration that's occurring in your joint right now. If we don't do anything with that joint, this degeneration is going to continue and continue and continue until your only option is a joint replacement. regenerative medicine, PRP and stem cells, when we do it, these procedures, when we're done well, it actually stops that catabolic degenerative effect that's going on in your joint space. And I think that's the biggest advantage of what this does.
Is there anybody that you would say, I mean, I know the answer to this, but is there anybody you would tell them, I don't think you're a great candidate?
I do. I mean, it's so somebody who has truly bone-on-bone arthritis, where you can't even bend your knee because it hurts too much, or you can't even put any weight on it because it just feels like barbs are in your joint every time you do that. Those tend to be not great candidates for it, because it kind of tells me you don't really have that healthy of a milieu or even enough tissue there for us to try and repair. So those are the kinds of things that I talk to. And when I do have these conversations with patients, I try and be really careful with the things that I say and then the advice that I give them, that if it does get to that point, then yeah, I think you are on what we call end stage with your joint disease, and then the best option would be a replacement.
Is there much difference, would you say, between the major joints, between the large articular joints in the body as far as the process goes? Is there a different process going on in your shoulder than the hip and the knee, or is it all pretty much the same?
I mean, I would think it's all pretty much the same. The how I would treat one or another kind of would also probably would differ, probably, depending on kind of what I see. I tend to recommend more stem cells, like bone marrow stem cells, for weight-bearing joints and large joints like hips and knees, ankles, spines, things like that. For things like shoulders, fingers, elbows, toes, stuff like that, like smaller joints or non-weight-bearing joints, I tend to gravitate more recommending PRP. But again, it's everyone's kind of different. You kind of take what everyone's goals are, what they present with, and we present them with the best recommendation based on kind of what we've learned all these years of doing this. What about you? Do you do anything different?
Yeah, I agree with all of that. The biggest difference between PRP and stem cells, I summarize in one word, as being potency. Both stimulate growth and healing. A stem cell procedure does work a much stronger degree than a PRP procedure does. So if it's an area of the body that's under a lot of force, a weight-bearing joint, or if it's an area of the body that doesn't have a great blood flow, I typically recommend stem cells over PRP for those structures. Whereas if it's a great blood flow area, not a weight-bearing, not a really heavy load receptive tissue, PRP is usually sufficient.
Yeah.
All things being equal, I do bone marrow every time. The stem cell bone marrow is cost. It's more expensive than PRP, and if we can get away, quote unquote, with a PRP procedure, we prefer to have patients spend less money and still get a great outcome. That's really something we pride ourselves in. Not recommending everybody have the same procedure. It's not a one-stop shop kind of one-size-fits-all kind of place. We really do cater what we recommend to our patients, to the disease, to the severity, with the end goal to get a good outcome. That's always our end goal.
Yep. And then the other big advantage of bone marrow stem cells too is the way that we process that. We also get some PRP with that bone marrow stem cell. So we actually get a 2-for-1 when we go the stem cell route too. So what about this? Like, what about for patients that you see who are not good candidates for stem cells or PRP? What other things would you recommend for them?
Yeah, it depends on their goals. That would be a great role or a great surgical indication. If they're a great candidate for surgery and we're not a good candidate for a stem cell procedure, go have surgery. Try to get the problem fixed. Get your function out. Don't take pills every day. You don't have to come in for injections every 3 or 4 months. Just let's get the problem fixed. If you're not a good candidate for some reason, surgical indication, just your two other comorbidities, there's a high risk for something bad happening with a major surgery. Yeah, the pain management route's great. Or if you've had joint replacement and you still have pain, we have some excellent options for that. What just recently has kind of come into the market and been more commonplace is what are called peripheral nerve stimulators, which essentially placing a nerve under a wire under the skin. And it's a wire that has active electrodes on it that you can turn on and off. And when the pain's bad, you can turn it on and it shuts the nerve down. And then that nerve stays shut down for hours, if not days. And then the pain goes away. And then when the pain comes back, you turn that stimulator back on. And again, it shuts the nerve down. Because of the nature of these nerves, they're buried relatively deep. What happens electrically with the signal, it's something you can't stimulate from the outside. These nerve leads need to be implanted under the skin, but they're like little spaghetti strands. They're really, really thin. They're very flexible. Patients who have them generally don't notice that there's any kind of discomfort or any kind of problem, and they have full control over when that nerve stimulator goes on and off. That would be something I would highly encourage somebody to entertain the idea if they're having a lot of pain after a joint replacement.
Yeah, yeah. Same here. So I kind of, that's one of the things I would recommend for somebody that comes in who already had a joint replacement and continues to have pain. But more and more, I'm actually finding offering it to patients too who, you know, again, like you said, are not great candidates for surgery, but for one reason or another, either can't afford the PRP or the stem cells, or for their comorbidities don't allow it. I think it's a nice added addition to the toolbox that you could do before or after surgeries, you know, to relieve some joint pain there.
Yeah. And so kind of to that comment, right now, PRP and stem cells are still considered experimental by most every major insurance carrier. It's an out-of-pocket expense versus these other things we talked about, the peripheral nerve stimulators, the joint injections, knee replacements. Those are recognized as being standard of care and are covered by insurance with applicable deductibles and copays. So all of those come into our consults. We bring up those things. I don't think those are problems or taboo topics to talk about what's covered, what's not, determining what's right for you. And again, something we pride ourselves in is really tailoring that treatment plan to the patient with all the different circumstances in mind.
Yeah, I agree. I think it's one of the things that's really unique about our clinic is because we have a whole plethora of options for patients, whether it's insurance covered or not insurance covered, you know, out of the box type treatments. You know, we have all of that.
So on that note, if you have an arthritic pain or know somebody who does, and you would like to set up a consult with us, Michigan Center of Regenerative Medicine, Dr. John Santana, Dr. Tom Nabity. We do telehealth visits. If you're looking at this from and you live a distance away and you don't necessarily want to drive to the office, we're happy to do telemedicine visits, review all your imaging, and discuss things with you over a video chat. Otherwise, we're located in Rochester, Michigan, and we'd be happy to take a look and see if we can get you better pain control and better function.
Yep. You can give the office a call. Our number is 248-216-1008. Again, that's 248-216-1008. Or you can check our website, regenerativemedicinemichigan.com. We have a lot of information on there. We write a lot about topics on, you know, regenerative medicine and arthritis and treatments for that. And then we also do these monthly webinars. That's a good way to kind of educate patients too, and learn a little bit more about us and what we do here in the office.
All right, everybody, thanks for taking the time, and we'll let you go enjoy the rest of your evening.
All right. Good night.
All right. Good night, everyone.